exciting episode under the aegis of Mumbai Hematology Group. There has been many pillars of Mumbai Hematology Group. Professor Dr. M.B. Agrawal has been a pillar, and he has been bringing all the leading stalwarts into the respective malignancies, and today is going to be one on myeloid malignancies, the mutations, aberrations that we see. I'm extremely grateful to the gentleman on the screen as well, Dr. Amit Khurana, a leading hematologist and transplanter in India, and he has been anchoring this show very ably as well. Mumbai Hematology Group has been a pioneer in the field of hematology, and they have their academic contribution, not just to the country, but to at a global level, is immense. And we at INTAS are extremely proud of this collaboration. May I request Dr. Amit Khurana to introduce and take it forward from here.
Thank you, Dr. Manoj Kumar, for that kind words. So, very good morning to all of you, and good afternoon and good evening to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Professor Dr. Hans Sill from Austria, and he's going to lecture us on TP53 aberrations in myeloid malignancies. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and the team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Archana Swamy from Mumbai, our guest speaker for the day, Professor Dr. Hans Sill from Australia. All of our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 8th of February 2025, from 7 p.m. Indian Standard Time and 7:30 a.m. Chicago time, your Dr. Rukmi Bhatt from Chicago, US, is speaking to us on how I treat pediatric thromboembolism. And the following day, that is Sunday, 9th of February 2025, from 11:30 a.m. Indian Standard Time and 7 a.m. Austria time, your Dr. Roberta Russo from Italy is speaking to us on updates on clinical aspects and laboratory aspects of hereditary erythropoietic anemias. Let me introduce our discussions for the day, and they are here displayed in alphabetical order. To start with, we have Dr. Ankita Sen from Kolkata, Dr. Ashok Meshram from Kolkata, Dr. Aswini Narayankar from Kolkata, Dr. Bilal Kazi from Kolkata, Dr. Chandrakant MB from Kolkata, Dr. Ganesh Deshetwar from Hyderabad, Dr. Jaswantini AR from Hyderabad, Dr. Kripa Bajaj from Hyderabad, Dr. Kunal Goel from Mumbai, Dr. Nidhi Dixit from Kolkata, Dr. Pujita Bai Reddy from Hyderabad, Dr. Prantal Chakrabarti from Kolkata, Dr. Radhika KK from Hyderabad, Dr. Rajat Bhattacharya from Kolkata, Dr. Rajat Pincha from Kolkata, Dr. Sundar Shivale again from Kolkata, and Dr. Yogalakshmi S from Hyderabad. Now it's a time to introduce our special guest and chief guest for the day. We have with us no other than Dr. Archana Swamy from Mumbai. Let me introduce Dr. Archana Swamy. She is a pediatric oncologist and hematologist at B.J. Wadia Hospital for Children and Lilavati Hospital. She obtained her MBBS and MD degrees from the prestigious St. G.S. Medical College and KM Hospital, Mumbai, followed by MRCP in pediatrics from the Royal College of Physicians, London. Her training in her specialty of choice is from working in specialty hospitals in London as well as Singapore, in addition to the B.J. Wadia Hospital for Children. She specializes in pediatric hematology and oncology. She achieved training in pediatric hematology and oncology from London, followed by Singapore, and then B.J. Wadia Hospital for Children, which is a teaching hospital in Mumbai. She is a teacher for students doing FNB degree in pediatric hematology and oncology, and she has organized numerous conferences, workshops, and CMEs. She has published various peer-reviewed research articles and also chapters in books. She is a prolific orator and has been invited to deliver various guest lectures across the country. It's my privilege to welcome Dr. Archana Swami to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Archana Swami.
Thank you, Dr. Amit. Thank you so much for the introduction. Okay, first of all, good morning, good afternoon, everybody. And I would like to thank Dr. M.B. Agarwal for this opportunity and welcome Professor Sills for his much awaited talk. And just take 2 minutes to speak to the budding hematologist. So they have chosen the field of hematology, which appears so simple. It's just blood, but is also so complex. We now know it's not just RBCs, WBCs, and platelets. There are so many other components. There are inhibitors, there are factors, there are prostacyclins. Even the endothelial lining takes part in the hematological process. And we also have the molecular level, which helps us to innovate on targeted therapies, and we have the genetic level, which is very important nowadays because it helps us prognosticate, and it also helps us anticipate knowing the course of the illness. And when we are learning hematology, we are actually exploring life itself because blood is our lifeline. So as budding hematologists, we have to explore genetic research and immunology. It is related, and because of your contributions, budding hematologists in these fields, we hope to achieve new heights in hematology. But there's one thing I would like to point out is in between the white lab coats and research journals, there's one thing we need to keep in mind, and that is humanity. So when we break a new diagnosis to a person, say a hematological malignancy, a child, the father or the parent, the caregiver has never heard of it. It's news to him. And even if they find out, they Google it and so on, they will still come to you for solace. They come to you for guidance. They come to you for assurance. And I think the fact that you guide them through it, celebrate small victories that the patient has, and also console them when things don't quite go where they need to. I think that is a big part in addition to your expertise in the matter. So all I can say is, although it's challenging, I think you can do it. It is not just a field of medicine. It can be a calling, depending on how much passion you have for it. And all I can say is you need to collaborate. You need to embrace all your mistakes. The only person who does not make mistakes is someone who doesn't try anything new. So that I hope will not happen. You need to try, you need to collaborate, you need to innovate, and you need to keep the spark of hematology alive, which is what has brought you to listen to my lecture today. And I hope this goes on. So all the best to everyone. And that's the 2 minutes I have. Thank you so much.
Thank you, Dr. Archana Swami, for that wonderful words of wisdom. You're really given a spark to all of us today, this Sunday morning, with your sparking words of wisdom. Thanks a lot for being our chief guest for the day. And this will be really helpful for all our budding hematologists from now on. Let me introduce our guest speaker for the day now. So our guest speaker for the day is no other than Professor Dr. Hans Sill from Austria. Professor Dr. Hans Sill is Professor of Leukemia Research at Division of Hematology, Medical University of Graz, Austria. His education and training include, in 2002, he underwent postgraduate training at Fred Hutchinson Cancer Research Center, Seattle, USA. 1995 to 97, subspecialty training in hematology and oncology at University Hospital of Graz, Austria. 1993 to 1995, he underwent research fellowship, Center for Adult Leukemia, Royal Postgraduate Medical School, London, UK. 1989 to 1993, he completed his residency in internal medicine, University Hospital Graz, Austria. 1985 to 89, he underwent rotating residency, County Hospitals of Steyr, Austria. And 1985, he underwent MD at University of Graz, Austria. His primary interest in research lies in understanding the pathogenesis of myeloid neoplasms in AML and MDS with TP53 aberrations. His research team at MUG showed that in these disorders, acquired mutations affect pre-leukemic stem cells and postulated that AML and MDS with TP53 aberrations should be regarded as a distinct disease entity. Furthermore, his group described that TP53 mutations may exhibit different functional properties, and even subclonal mutations contribute to a high level of therapeutic resistance based on data of the German-Austrian AML study group. His group also was interested in predisposition to neoplastic disorders, having described germline mutations in TP53 in patients with AML and reported for the first time germline mutations in CRAF in AML and SEMA4A in familial colorectal cancer, respectively. He worked in his group and is primarily supported by the Austria Science Fund and the NGO Leukemie Hilfe Steiermark. And today he's with us and he's going to lecture us on TP53 aberrations in myeloid malignancies. Well, thank you so much. Over to you, Professor.
Yeah, dear Dr. Swami, Dr. Kuma, and Dr. Karami, dear colleagues, many thanks for this very kind introduction, and also thank you very much for inviting me to this presentation, to this lecture. As already pointed out, the topic of the talk is or are TP53 aberrations in myeloid neoplasms. And some years ago, hold on, I'm unable to move it now.
Just click on the...
Yeah, I'll do it again, yeah.
You will to share again, sir.
Yeah. Yeah, now it works. Some year ago, this was stated as headline in this magazine, Elephants Don't Get Cancer. And it is based on an original article. And the reason for that is that elephants have 20 versions, so 40 alleles of TP53. So P53 is a very important molecule, both physiologically and pathologically. And my agenda will be to spend some words on P53 physiology, to have also some general remarks on TP53 aberrations and their consequences. And then I'm going to focus on some entities or conditions. Lieframeni syndrome, P53 in clonal hematopoiesis, and I would like to present also some own unpublished data, and focusing on P53 in acute myeloid leukemia and myelodysplastic syndromes. I do not have any conflicts of interest with respect to any part of this talk. So P53 is located at chromosome 17p, the short arm of 17. And it contains 11 exons, and it has 2 promoters. And it has important functional domains. Transactivation domain, proline-rich domain, and a very important DNA binding domain, and a tetramerization domain. And at least 12 different isoforms are known. And some of these isoforms are also expressed in various forms of malignancies. P53 is expressed by many, many different stimuli. The main stimuli are DNA damage, oncogene activation, oxidative stress, and nutrient deprivation. And P53, once activated, activates many, many hundreds of different pathways. With respect to our field, hematological malignancies or malignancies in general, these are DNA repair and senescence, apoptosis, metabolism, and cell cycle arrest. And importantly, once P53 is activated, it forms tetramers, both physiologically and pathologically. So P53 physiologically has also a very important function in hematopoietic stem cells. It governs quiescence and self-renewal. And as you can see here in the seminal work, red P53 wild type hematopoietic stem cells, blue P53 knockout stem cells. And these knockout stem cells cycle significantly more than the wild type cells. With respect to P53 aberrations, they start in a monoallelic form. And there are mainly mutations, missense mutations observed. Very rarely we see initially insertions or deletions. And during progression towards malignancies, in the case of clonal hematopoiesis, or during progression within a malignancies, monoallelic aberrations transform into biallelic ones. And the mode of action is either chromosomal loss, whole chromosomal loss, or loss of the short arm, loss of heterozygosity, or uniparental disomy, or even transmutations occur, an independent mutation on the second allele. So a vast majority of mutations occur in the DNA binding domain. And P53 mainly, but not exclusively, acts as a transcription factor. We also know protein interactions of P53. And we have hotspot mutations, for example, R273 and other ones, which are listed on the right side. And the reasons for hotspot mutations may be either a common exogenous or endogenous toxicity, or a certain structure at this DNA site. Importantly, as I already pointed out, P53 forms tetramers. And you see on the left the physiological form, 4 normal P53 molecules. In the mutant forms, we have also tetramers with 1, 2, 3, or even 4 mutant P53 molecules. And according to this, we have different consequences. It is very, very well known that P53 causes loss of function. But we also have the dominant negative effect in these cases with 1, 2, or 3 mutant molecules. In this way, the mutant form suppresses the function of the remaining wild-type P53 alleles. And there is debate, and there is still debate, is there a gain of function of mutant P53? Gain of function means that novel functions are coming up. And we have evidence for gain of function effect from literature ranging 3 decades back, when mouse models were generated with P53 loss or P53 mutations. And these mouse models acquire different neoplasms at different time points. So there is indeed also a gain of function effect of mutant P53. Very important, P53 acts context dependent. It's important in which cell, in which organ P53 mutations occur. So let me come to the conditions I'm focusing on. Germline mutations characterize the Li-Fraumeni or the Li-Fraumeni-like syndromes. We know very well the occurrence of P53 in clonal hematopoiesis. And we have somatically acquired P53 mutations in more than 50% of human malignancies. As you can see here, this is a pedigree we have observed in our hospital. 3 generations, and you see here, 1 patient with thyroid cancer, colorectal cancer, breast cancer twice, and therapy-related AML. The father had secondary AML. You see also here individuals with breast cancer and a peripheral neuroendocrine tumor. And this family has a P53 germline mutation. And this syndrome is characterized by almost 100% lifetime incidence of malignancies, mainly consisting of brain tumors, breast cancer, sarcomas, leukemias, and adrenal cortical tumors. And once we face tumors with a P53 mutation, it's important to think, could this individual, could this family have a germline event? And it's sensible to ask for family history, for careful personal history of cancer, because it has consequences. And if we compare the mutational landscape between somatic aberrations on the right and germline aberrations, the mutations are quite similar, quite comparable. It is mainly the hotspot mutations R175, 248, and so on. But as you can see, there is a different tumor spectrum. In the somatic form, mainly colorectal, also brain and breast, but lung and ovary. And this is a very interesting study, observing, and not only observing, but also offering a surveillance of Li-Fraumeni individuals, which are not diseased at the time of study entrance. And there's a lot of investigations which have to be done. Blood work, whole body, MRI examinations, till prophylactic mastectomy. And this is a lifelong program. But as you can see here, the survival of individuals with P53 germline mutations is significantly better as the survival of individuals with no surveillance. So please, if you have a patient with a tumor, and whatever the tumor is, with a P53 mutation, think about, could this a germline event, and maybe you examine also normal, non-affected tissues. Clonal hematopoiesis has described many decades before, but it became very attractive about a decade ago. So you're aware of the concept of clonal hematopoiesis. A hematopoietic stem cell gives rise to differentiated normal blood cells. But in the course of aging, mutations occur in this hematopoietic stem cell, transforming them to pre-leukemic stem cells. And these pre-leukemic stem cells are still capable to differentiate into mature blood cells with almost normal function. But these are clonal cells harboring also the mutation. And if further events occur, pre-leukemic stem cells further develop to leukemic stem cells, and they may give rise to hematological malignancies, myelodysplastic syndromes, or acute myeloid leukemia. So this is the very important leukemia stem cell concept. So how frequent is clonal hematopoiesis? And of course, it depends on the tool you are using. With a WAF variant allele frequency threshold of, let's say, 3 and 7%, we have clonal hematopoiesis at the age of 70 between 10 and 20%. But if you use more sophisticated sequencing tools like error-corrected sequencing, we have much, much higher frequencies. So clonal hematopoiesis is not only associated with hematological malignancies. It is associated with cardiovascular disease, giving rise to myocardial infarction or stroke. It is associated with chronic pulmonary disease, chronic kidney disease, chronic liver disease. And interestingly, it is associated with a decreased risk of Alzheimer's disease. This is a seminal paper and a seminal experiment showing the mode of action, how P53 mutations work. This is a mouse model, an immunocompromised mouse model, and the authors have transplanted both TP53 wild-type cells and TP53 knockout cells. When these cells engrafted, they treat one cohort of mice with ENU, ethyl nitrosourea, an alkylating agent, or with vehicle. And as you can see, those mice which were treated with chemotherapy showed a significant increase of P53 knockout cells and also P53 leukemic stem cells. So that's the main concept P53 mutations work. Mainly under cytotoxic stress, they do not lead the cells into apoptosis, senescence, or whatever, but they give rise to expansion of this clone. And similar takes place with the other DNA damage response genes, PPM1D, ATM, and JAK2. So what's about the adult situation? Clonal hematopoiesis is very common in the adults, starting with the age of about 50 years. And P53 mutations are also very common, apart from the classical one, TDA, DNMT3A, TET2, and A6L1. And again, as in liver, many patients, as in hematological malignancies and as in other solid tumors, these are mainly about 90% missense mutations. And if you look at a very large cohort, almost 25,000 patients with solid tumors at the time of diagnosis, these DNA damage repair pathway genes, these mutations in these genes increase with age, and they increase under cytotoxic stress. So this is a common mechanism of expansion of P53 aberrant clonal hematopoiesis towards hematological malignancies, also in the human situation. There's also a score, a clonal hematopoiesis risk score described. What is important, certain mutations, high-risk mutations, and P53 is regarded as a high-risk mutation, the number of mutation, the variant allele frequency, and also some red cell indices, cytopenia, and age. And using this score, we can exactly determine the risk of a patient coming to the clinic with clonal hematopoiesis, the risk for hematological malignancies. So I would like to share some unpublished data of our group generated by Karen Lind and Shai Anthony Dutta. What is very important in P53, as already pointed out, is the allelic state. And we were interested on the allelic state in primary human hematopoietic stem and progenitor cells derived from cord blood. And we can study these monoallelic or multiallelic or biallelic aberrations here without the influence of other aberrations in other genes. So what was the system, or what is the system? We used CRISPR-Cas9 to generate P53 aberrations in these human stem cells. We targeted exon 2, and by homologous recombination, we introduced cDNAs, either for wild type, for mutant P53, or for knockout P53. With the latter case, we introduced a cDNA with a stop codon. And we were able to do this on one allele or on both alleles. And we generated two hotspot mutations, both in the monoallelic and in the biallelic aberration, a knockout, and as a control, we used wild-type sequences, or we targeted the AAVS1 locus. And the first thing we asked, what's about growth? And we did colony work, and we were able to show that biallelic aberrations form significantly more colonies than monoallelic aberrations or the wild-type situation. And interestingly, and this has also been described in the human settings, there is a significant trend towards a formation of erythroid colonies. And as you may know, erythroid leukemias in humans harbor to a very high extent P53 aberrations. These biallelic stem cells cycle more, and we were able to replate them for at least 5 times. Not the wild type generated cells, nor the monoallelic aberrations. So this means that the second allele generates a growth advantage. We did also genomic instability studies. This is a single cell template strand sequencing technique. And here's an example of one mutation, the R175 mutation. Here is DMSO, the control, and doxorubicin. And as you can see, they form significantly more chromosomal aberrations, both in the monoallelic form and in the biallelic forms. And there's no significant difference between mono and biallelic aberrations. And we did also bulk RNA sequencing. And as you can see here, there's not much difference between monoallelic and biallelic aberrations. The main set of significantly transcribed, differently transcribed genes are the same. And if you look at the genes and pathways which are upregulated, in both conditions, we have chronic inflammatory genes and pathways, TNF alpha signaling, interleukin 6, interleukin 2 signaling. And this leads to our preliminary hypothesis with monoallelic aberrations. There's already genomic instability, and there is already the induction of a chronic inflammatory pathway. And the second allele gets lost during progression, and it mainly mediates further growth. So let me come to the human leukemia setting. P53 aberrations occur in about 10 to 15% of AML and MDS, and as already pointed out, they are increased in erythroid leukemia in therapy-related myeloid neoplasms. In myeloproliferative neoplasms, TP53 aberrations are progression factors, heralding the transformation to either MDS or AML. So this was one work we did asking which cell compartment is affected by P53 mutations, and we did both NGS studies, so immunocompromised xenografts and human specimens, and we injected P53 AML specimens into these mice, and most of them engrafted, and some of them also differentiated into granulocytes and lymphocytes. And all engrafted cells, blast cells, granulocytes, as well as lymphocytes, harbored the specific P53 aberration. And when we sorted T lymphocytes, we were also able to demonstrate that in a significant proportion of these human T lymphocyte specimens, the specific P53 mutation is detectable. So this led to the conclusion that P53 aberrations are very early events affecting pre-leukemic stem cells. So what happens during oncogenesis, during leukemogenesis? The second allele gets lost. And we have in this very recent work a multi-hit status in almost 70% of MDS cases and more than 90% of AML cases. And these aberrations are copy neutral loss of heterozygosity, a copy loss, or the occurrence of a second mutation. And if you look at the right side, these is a SNP area, and you see a huge number of copy number aberrations, of chromosomal aberrations. And this is the classical genetic instability form of P53 mutated myeloid neoplasms, complex karyotype chromotripsis with a huge number of gains, of continuous gains and losses, and so on. So we see very few mutations incorporating genes, but we see chromosomal or structural chromosomal aberrations. We sorted CD34 positive cells of patients with MDS and AML, and these neoplasms are mainly CD34 positive, and we assessed myeloid markers as well as apparent markers, and you can see there is no difference between CD34 positive cells between MDS and AML patients. And we and others concluded that P53 aberrant MDS and AML can be regarded as a distinct disease entity. From normal stem cells, clonal hematopoiesis occur, and under the influence of cytotoxic stress, mainly under this influence, AML and MDS occurs. Interestingly, if P53, if wild-type P53 is hyperactivated, it leads to cytopenia. And hyperactive P53, wild-type P53, is observed in many bone marrow failure syndromes. So this is also a seminal work by Bernard et al., published a few years ago, showing the importance of the allelic state in myelodysplastic syndromes. And as you can see here, in the monoallelic form, the prognosis to survival is similar to the P53 wild-type status, and only the multi-hit form leads to an inferior prognosis. And this holds also true, of course, for the relapse incidence. This data could not be confirmed by the Dutch group, showing at least in high-risk MDS in AML a very similar outcome of multi-hit and single-hit p53 mutations. The novel ICC classification now discriminates between MDS with mutated p53 with a bone marrow or peripheral blast count of 0 to 9%, MDS AML with mutated p53 with a blast count of 10 to 19% with any somatic p53 mutation, and AML with mutated p53 with 20% plus in the bone marrow or peripheral blood or more. And there is the MDS IPSSM risk calculator, which we also use where you have to insert many different parameters, and you really get the risk classification for patients with MDS. And this is a good basis for therapeutic decision making. So, what is the current status to assess the p53 locus? It is karyotyping, of course. It is FISH, including a 70p probe, and is targeted sequencing. And as the locus, the allelic state is very important. Recently, it was recommended whole genome sequencing, whole exome sequencing, and we can have a discussion about that. How is this feasible in general clinical practice? So let's come to therapy. And I have to say at the beginning, I'm not focusing on treatment options we failed, and I will like to focus only on very few phase 1-2 trials. So the first option is enrollment of patients into a clinical trial if available. Why? Because the prognosis of p53 patients is very, very inferior. This is data from the German-Austrian AML study group, and we analyzed the role of p53 mutations and subclonal mutations with a variant allele frequency of less than 20% or 20 to 40%, almost 1,500 patients. And as you can see, any p53 mutation confers a very inferior survival as compared to the p53 wild-type patients. And this also holds true in multivariable analysis. And this also holds true not only for the overall survival, but also for the event-free survival. And this is again in the human setting how it occurs. And this is a patient we treated many years before, an older patient with myelodysplastic syndrome. He had two p53 mutation, one with a high VAF, more than 40%, and one with a very, very low VAF. And this patient transformed to secondary AML, acquiring a novel KRAS mutation. And then we treated him with 2 lines of intensive treatment, 3+7, idarubicin, FLAG-IDA. And nevertheless, the clones expanded and the patient died of progressive disease. So p53 mutations are resistant to conventional therapy, and these clones expand. And this is mainly true for remaining p53 mutated leukemia stem cells. It is conventionally almost impossible to eradicate these leukemia stem cells. They remain in the bone marrow, and they are the source of a fulminant relapse. So these are data with venetoclax azacitidine. Most of the data came from the VIALE-A trial. This is a subgroup analysis with p53 mutations. and in the poor risk cytogenetics group, in the intermediate risk cytogenetic group. And what you can see here with patients with P53 mutations, a very high proportion achieves complete remission. But the overall survival is still poor. About 5 months with P53 mutated patients treated with venetoclax azacitidine, and almost the same treated with AZA alone. And we also can discuss now how to approach these patients outside the clinical study in daily routine. Very new work last week published in Blood outlined, can we in these patients predict the response to venetoclax, an ex vivo drug screening. And you can see here 2 cohorts, an untreated cohort and a refractory cohort. Blue, those patients with responded ex vivo to venetoclax and showed also a complete remission. And red, the patients with did not respond ex vivo to venetoclax and did not show a remission in vivo. And as you can see, there's a really very high concordance between ex vivo drug testing results and the clinical outcome. And if you look at the survival curve, venetoclax treated patients which responded ex vivo showed a median overall survival of almost 29 months. Very, very good correlation. And the other drug testing approach is this by the German group. They calculated a score, the max score, BCL2, which is the target of P53, divided by BCLX and MCL1. So BCLX and MCL1 are proteins which are upregulated during the course of venetoclax treatment. And these are anti-apoptotic proteins and are resistance factors. And as you can also see here, this score gives also a very, very good prediction to venetoclax treated AML patients in general. I have to confess at this stage, if you look at the subgroups, the tests, both tests, are not very accurate in predicting the response again in P53 mutated patients. So this is a meta-analysis of all studies done so far on chemotherapy, hypomethylating agent, and azacitidine on P53 mutant AML patients. And as you can see here, either approach, whatever it is, has a very low median overall survival of 5 to 6 months. And this led to the conclusion of the authors, and we also can discuss this later on, to treat these patients only with azacitidine. So a novel approach, and one of the very few phase 1 trials I would like to show is this one, the treatment with disetabine, oral disetabine, and venetoclax. And you can see there's an overall survival, a median overall survival of more than 8 weeks. And this gives some hope that this holds also true in the phase 3 trial, which was already performed. Still a very attractive approach, although ebrenatobop just failed, is reactivation of mutant P53. So P53 mutations disturb the structure of the molecule, and the tetramer cannot bind to the DNA of targeted genes anymore. And a novel approach is rezatopopt, which is designed just for one specific mutation, the Y220C mutation, which is similar to the RAS situation. And this is what we call a tumor agnostic approach. So it can be used in any human malignancy where this P53 mutation occurs. And if you go at clinicaltrials.gov, some studies are already coming up in solid tumors, and there are also studies planned in patients with P53 mutation, with this specific P53 mutation in MDS and AML. And also another interesting approach is arsenic trioxide, which is used, as you know, in acute promyelocytic leukemia, which is also now tested in early clinical studies, which is also a P53 reactivation molecule. So this is an important slide about allogeneic hematopoietic stem cell transplantation in P53 mutated MDS. On the left side, you have patients with P53 clearance in complete remission. And in this condition, you see a significant survival difference between blue allogeneic transplantation and red conventional therapy. But this does not hold true if the patients are not in remission. And the same is the case with acute myeloid leukemia, the prognostic parameters, achievement of a first complete remission and a good performance status. So you can achieve with allogeneic transplantation at least a 1 year survival of about 70%. So allogeneic transplantation at present is the only therapy which can cure TP mutated AML and MDS. And important to discuss a maintenance therapy also post-allogeneic transplantation in this patient cohort. The reason is many P53 mutant leukemic stem cells are even surviving the transplantation approach. I would like to show this slide, which is already 35 years old, but this landmark paper, thousands of times quoted, allogeneic transplantation in chronic myeloid leukemia. And the authors at that time asked the question, what is the probability of relapse? And the relapse was highest in identical twins, and the relapse was lowest in those patients undergoing transplantation and complicating by graft versus host disease. Those patients have the least likelihood of relapse. And the authors concluded very, very correctly, there is sort of a graft versus leukemia effect. So the novel immune system plays a major role in eradicating leukemic stem cells. And of course, this is also true in acute myeloid leukemia. We do transplants in the adverse risk setting, in the intermediate risk setting, and also in P53 mutated leukemias. And indeed, the immune system is highly deregulated in these patients. You see here several immune parameters. The immune score, the inflammatory chemokine score, the interferon score, the lymphoid score, and you see certain AML subgroups. And with all scores, the P53 mutant samples are highly deregulated. So there is a place for immune therapy in this particular cohort of AML patients. And a novel approach, DAR dual affinity receptor targeting approach, targeting the CD123 antigen and combining it with CD positive T cells was already performed, showing a very, very good outcome of course, again, a phase 1/2 study in P53 mutant AML patients. So there is a place for P53, and currently also a search is undergoing for P53 specific, leukemia specific antigens, and maybe degradation products of P53, which are expressed in the cytoplasm or on the cell surface, can function as these novel leukemia specific antigens and make also CAR T cell therapies very attractive. At present, there is no place for CAR T cell therapies outside clinical trials in AML in general, but in particular in P53 mutant patients. So let me come to my conclusions. In human malignancies, P53 aberrations are mainly missense mutations, conferring loss of function, dominant negative, and gain of function effects. TP53 aberrant myeloid neoplasms are characterized by typical biological and clinical features and can currently only be cured by allogeneic transplantation and reactivation of mutant P53 and immunological approaches might improve the prognosis of these patients. Last but not least, I would like to thank the team, our collaborators, and those who support us with grants. And last but not least, I would also like to thank you for the invitation and your attention. And I'm looking forward to the discussion.
Thank you, Dr. Sil, for that wonderful lecture and throwing light on this complex topic of complex TP53 mutation. Tough job for all the patients, but thank you so much for wonderful lecture, sir. And I now request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Sil. First, we have Dr. Rajat Bhattacharya. Your question, please.
Thank you. That was a fantastic talk. Wonderful. Thank you so much. My question is the role of decitabine in TP53 mutation, mutated AML. There's some evidence that decitabine was better demethylation agent. Is that does it still hold true? Is there any scientific basis on it?
Very good question. Very good question. Heavily discussed question. You know the data, the initial data published in the New England Journal of Medicine with decitabine achieving 100% complete remission rates. Decitabine was also tested in the VIALE-C trial with venetoclax. The current evidence is that decitabine is not better than azacitidine, nor is it to double the dose. So it is, at least in my country, common clinical practice to use venetoclax together with azacitidine, but you can also use decitabine. What is very promising, the one slide I have shown about the phase 1/2 trial published in Lancet Hematology with oral decitabine, oral decitabine and venetoclax. This triple combination might offer hopes. You do not need a parenteral formulation, and at least the preliminary data show very encouraging results with a median overall survival of more than 8 months in this particular patient cohort. This is almost double the time as with any other conventional approach. So decitabine might be a hopeful strategy in combination oral decitabine in the future.
Thank you.
Thank you, sir. Dr. Ashok Mishram, your question, please.
Thank you, Professor Still, for a beautiful lecture. My question is regarding in your new article 2022 regarding molecule April APR 246 compound to restore the function of mutant P53. So role of these drugs APR 243 and MDM2 inhibitors and dual MDM2 and MDMX inhibitors.
Yeah. Also a very important question, a very important question. APR 246 is also a drug that reactivates mutant P53. And the initial data published in Cancer Cell, I think about 15 years ago. And there was a large clinical program by Aprea Pharmaceuticals to further develop API, eprenatopopt. And there were very encouraging phase 1, phase 2 studies, also in patients with AML and MDS. And unfortunately, the data of the phase 2 trials in both AML and MDS patients with P53 were not encouraging, and Aprea Pharmaceuticals finished this program. So APR is not available clinically, and this program is not pursued anymore. There's one condition where good results were obtained, but it is questionable if the company also pursues this very small topic, and this is maintenance therapy after stem cell transplantation. There was also a trial that showed encouraging results, and at present is unclear. But APR, and there was also experimental report by the Strasser group from Australia, showing very interestingly, in contrast to the initial data, that APR affects also cells with a P53 wild type status. And the second question. The second question you had is MDM2 inhibitors. We also took part in this clinical study in relapsed refractory patients. It did not show superior results. It had severe side effects, mainly from the gastrointestinal side. And with MDM2 inhibitors, we have to take into account that only P53 wild-type patients respond. P53 mutant cells are unable to respond to an MDM2 inhibitor.
So regarding double MDM2 and MDMX inhibitor, dual inhibitors.
Yeah, these are hopefully strategies to target also resistance factors which are upregulated. I showed you the MRC, the MAC score, and these are early clinical studies which are now going on, but we have to wait until the final results. Also with this particular entity, as you have experienced with many other studies in the past, they are encouraging phase 1, phase 2 trials, and in the end, phase 3 is the very, very big hurdle for any novel drug to show really a significantly superior response and to show that the drug is not too toxic. We will see, but this is a hopeful and interesting current approach to target resistance factors together with venetoclax combinations.
Thank you, sir, for very nice and lucid lecture. And what a research data in a mouse model and impact of a cytotoxic stress, which leads to second myeloid malignancies. Very amazing. Thank you very much, sir.
My pleasure.
Thank you, Dr. Ashok Mishra. So, sir, should we say that in 2025, in those patients who are not transplant eligible and who has got TP53 mutated AML or MDS should be given only azacitidine?
That's a good question. I would like to ask you, what are you doing with these patients? Are you doing combination therapy? Are you doing monotherapy? We have discussed this intensively in our department, also in Austria, but I'm very interested in your answer first. What are you doing with these patients?
So there are many schools of thoughts now. Some of them are only going for AZA plus Ven both. Some for AZA Ven for few cycles and then stop Ven and continue with only AZA. And some of them will go only for AZA Ven short duration, say 5+5 for a couple of weeks and then stop Ven again and then only continue with reduced dose of AZA long term.
Yeah.
So this is difference of opinions from everybody, but we want your opinion. What
Yeah.
should be done?
We have discussed it thoroughly, and we decided on doing in fit patients, but which are unfit for transplant, to do the combination venetoclax azacitidine. And our rationale was we have a very high amount of complete remission. So this means that the counts in these patients are good and the quality of life is very, very good, in contrast to patients with no remission, where the counts are usually low, the white blood count, the platelet count, and so on. So that was our argument in favor of the combination. And some of these patients also they improve in their general condition and can go towards stem cell transplantation. You have to take into account, honestly, and you have experienced this as well, the toxicity of the Ven-Aza approach. Severe cytopenia, long-lasting cytopenia. So also in some patients, which are in a very bad condition, we start now only with azacitidine monotherapy. But also in younger patients, in patients with a very good general condition, we start with Ven-Aza, hopefully achieve a complete remission very soon, and then we offer transplantation. And in the meantime, we are going for a donor search and all the things which are necessary in the preparation of stem cell transplantation. But it's a heavily debated question internationally. And it's also in many countries a matter of costs. Ven-Aza, of course, is much more expensive than azacitidine monotherapy. But for transplantation, you need a complete remission. These are unambiguous data. You should not transplant in a full-blown P53 mutated to target these leukemias to achieve a remission. A good approach is venetoclax azacitidine. So we are more in favor of the combination.
And the patients who are not going to take for transplant, is it okay then go for only AZA for cycles and then only AZA after that?
Yes, yeah, very good approach. Very good approach. Yeah, possibly or very likely, you should not discontinue despite a complete remission, because you cannot eradicate leukemia stem cells with this approach, and the relapse will come up.
Thank you so much, sir. Dr. Pujita Reddy, your question.
Hi, sir. Good afternoon. Sir, my question is out of today's context, but it's a basic doubt. What is the role of TP53 mutation testing in ALL? And if so, if the patient has TP53 mutation, do we consider upfront transplant in this patient even with an allelic frequency of less than 30%? Sir?
Yeah, I'm not an expert in acute lymphoblastic leukemia. Yeah, but we still know that P53 also is a genetic feature of acute lymphoblastic leukemia. And interestingly, a similar work was published only, I think, 1 year ago, showing that P53 mutations affect also pre-leukemic stem cells in acute lymphoblastic leukemia. So taking this into account, P53 is also a high risk factor for treatment failure in acute lymphoblastic leukemia, and it is advisable, if possible, for other conditions to do also transplant in these patients. Otherwise, it would be impossible to eradicate all P53 mutant leukemic stem cells in acute lymphoblastic leukemia as well.
Thank you.
Thank you, Dr. Pujita. Dr. Ashok Meshram, you had another question?
Sir, question regarding role of magrolimab inducing tumor cell phagocytosis in P53 mutations.
Magrolimab was also a very, very hopeful novel strategy targeting CD47, so targeting the so-called don't eat me signal. And magrolimab has very, very interesting phase 1, phase 2 studies also published in high-ranking journals. And there was a particular study of magrolimab in the subgroup of patients with P53 myeloid malignancies. But again, in phase 3 trials, this drug failed. And the company also closed down the magrolimab program in part due to very severe side effects. So they are not pursuing magrolimab anymore, neither in AML nor in the particular subgroup of P53 mutant patients. And yeah, that's the case with many hopeful, promising drugs that they fail in the phase 3 setting. And this was also the case with magrolimab.
Thank you. Thank you very much.
Thank you, Dr. Ashok. Dr. Yogalakshmi?
Thank you for the wonderful lecture, sir. Sir, I'm treating a patient with the TP53 germline mutation. He's almost 3.5 years old child with transfusion-dependent anemia, and there is bone marrow fibrosis. And there is another mutation in his germline, which is firm T3, which is known to cause leukocyte adhesion deficiency type 3. So how to treat this child, whether with the bone marrow transplant, or should we screen for any leukemias also? We don't know what is the cause of the only transfusion-dependent anemia, but the bone marrow is fibrous and there is no hematopoietic elements which can be seen in the bone marrow.
There is no malignancy, so this is really a very difficult, a very difficult case. Honestly, I do not want to answer this question instantly because it has really consequences. And I would like to offer you to get in touch with me via email to exchange more data on this patient and to really lead a thorough scientific discussion. I would not like to give a recommendation just now, but my email is in the internet, of course, and maybe the Mumbai Hematology Group has also my email. So please get in touch, present this case with more data, and let's discuss it thoroughly.
Sure, sir. I'll be in contact. I will mail you the details.
I would
Thank
like,
you.
I do not want to give now a recommendation. That's too difficult.
Okay, sir. Okay,
Thank you,
sure,
Dr.
sir. I will be in touch. Thank you.
Yeah.
Thank you, Dr. Yogalakshmi. So there's questions from the audience. Dr. Karan wants to know that how would you confirm copy number biallelic TP53 mutations?
Yeah, that's the important question. What tools are we using to really assess the copy number state? In clonal hematopoiesis, it is obvious that there is a monoallelic state with many other mutations too. although we do not have many single cell studies yet. And in the case of malignancies, MDS on AML, there is the recommendation of doing whole genome sequencing, whole exome sequencing. But honestly, this is a very laborious approach, a very expensive approach, a very time-consuming approach. You really need a very good setup and also a very expensive approach. We are not doing it in daily routine praxis. We are doing, as I pointed out, karyotyping, conventional karyotyping, seeing what's going on chromosome 17p. We are doing a FISH analysis with a specific probe for 17p. And of course, we are doing targeted sequencing. And if there is a high variant allele frequency, let's say above 50%, we can conclude this is a monoallelic, a multi-hit aberration.
Exactly. Thank you so much, sir. Another question from Dr. Othman. What is the proportion of patients who acquires second mutation like FLT3 or IDH? And is there any role of inhibitors in these patients who have got TP53 mutations along with FLT3 as well as IDH mutations?
Yeah, interesting question. Usually P53 does not coincide with these mutations. This is a very, very rare case. Very rarely we see P53 aberrations in the good risk MDS and AML groups. But if they occur, and this is outside, of course, of published evidence, we can discuss starting with an IDH inhibitor, maybe leading to a remission. But we also have to take into account that P53 remains in leukemic stem cells, and we have to do approach targeting P53, or we combine IDH inhibitors with azacitidine, doing a MRD analysis, measurable residual disease analysis. But most likely, even if we can eradicate the IDH mutant clone, we will still have evidence of a P53 mutant clone, and we have to think about allogeneic transplantation, which is best performed in complete remission. But usually P53 co-occurs with chromosomal aberrations, with copy number aberrations, even with chromotripsis. And there are many, many different genes, upregulated, downregulated, which really disturbs genomic integrity.
Thank you so much, sir. Dr. Hitabi has a question. Out of this two drug combination, EZA plus VEN, which is more toxic in terms of neutropenia, EZA or VEN?
Venetoclax, of course. Venetoclax, yeah. That's very well known from the studies also. We were also part of the VIALE-A study. This is a big issue. Honestly, the only issue with venetoclax that remains in terms of toxicity is the cytopenic issue, the neutropenia, thrombocytopenia issue. And this leads to approaches to give venetoclax only for a limited period of time. So giving venetoclax just for 2 weeks and then doing already a bone marrow. And if the complete remission, let the counts recover and continue with a reduced venetoclax doses. But the cytopenia, not the drug-drug interaction, that's something we can handle. Also the other side effects we can handle very well. But neutropenia is a major, or the most important issue that remains. And if you have complete remission, of course, you can also give GCSF, granulocyte colony stimulating factor, to improve the neutrophilic counts.
Thank you, sir. Another question from Dr. Prakash Nidhi Tiwari. Your opinion on the use of EZA-VEN in children with P53 mutation AML and MDS?
Very difficult question for me, as I never was involved in pediatric hematology. So in my hospital, in my university, adult hematology starts at the age of 18. One thing is that P53 aberrant MDS and AML very, very rarely occurs in younger human beings, so in children, in adolescents. So P53 is a mutation that occurs mainly in the older ones. We also see this in clonal hematopoiesis. The percentages of healthy individuals with P53 mutant clonal hematopoiesis starts to rise at the age of 50. Nevertheless, we have P53 also in children in the therapy-related setting after other cytotoxic treatments, and we have P53 mutations also in erythroid leukemias, which also take place in children. That's just a recommendation of myself. I cannot refer here to published evidence, but I also would go for azacitidine venetoclax in appropriate dosages, and the same as in the adult setting, the ultimate aim should be allogeneic stem cell transplantation.
Thank you so much, sir. Another question from Dr. Gopinathan. A patient he has is 60 years male who is transplant eligible, complex karyotype, TP53 with a VAF of 50%, DNMT3 mutation positive, NF1 mutation positive, post 3+7 induction failure. What would be your line of approach?
3+7 failure. I would. How many cycles did he read? 3+7.
One
cycle. All right. Yeah, I would go for venetoclax azacitidine. Giving full dose venetoclax azacitidine, waiting for at least 3 cycles. After 3 cycles in this setting, it is very, very unlikely that the patient achieves a complete remission. And if the patient achieves 60 years old, complete remission after 3 cycles of azacitidine venetoclax, I would go for transplant if a donor is available. Yeah, if he does not achieve a complete remission after 3 cycles, honestly, I would go for palliative care. We do not have any options. Maybe there is a AML relapsed refractory trial in your hospital available for these patients. You can enroll them, but outside a clinical trial, we do not have much hope to achieve really a good result, a long-lasting CR, or even a cure.
Thank you so much, sir. I've finished all the questions from the audience. And is there any discussion who would ask any other question to Professor Still? Well, I think there are no more raising signs and there are no more questions from the audience. So thank you so much for that fantastic lecture and about a wonderful discussion. Many of our doubts are just cleared of this complex mutation that is TP53 and this complex disease to deal with. Thank you so much.
All right.
Lecture, lovely discussion. Hats off to you. Wonderful. What a depth of knowledge you have regarding this subject.
Yeah, I also say thank you.
Yeah,
I also say thank you for the very kind invitation, the introduction, the very lively and very interesting discussion. And if you have further questions, remarks, just write me an email and let's get in touch in this way. So I wish you a wonderful Sunday and say goodbye. Bye-bye.
Bye-bye, sir. Thank you so much.
Bye-bye.
Bye-bye.